So for the toxicity of local anesthetics, realize that it can happen systemically in the central nervous system or at the level of the heart. Also, it can occur at the individual nerves. And then we'll talk about ways to treat this. So this is a nice table from Barish. It shows that at different levels of drug, you have different signs, symptoms of toxicity. Starting at the most lowest levels, 1 to 5 mics per ml of lidocaine, you have your analgesia, which is desired. However, if levels start to climb, you get these warning signs from the patient. Patient may be lightheaded, ringing in the ears, periorbital numbness. These things are warning signs that the drug levels are too high, and soon you may be seeing more toxic signs such as seizing or respiratory arrest or cardiovascular collapse. Also notice that higher drug levels are needed for cardiac toxicity as opposed to neural toxicity, which can happen at lower levels of drug. And the potency of a local anesthetic in terms of its ability to cause analgesia actually correlates with how toxic the local anesthetic is. So there are different factors that can affect the toxicity of a local anesthetic in the central nervous system. So factors that will increase toxicity are acidosis, increased PCO2, and decreased protein binding. And on the other hand, things that can decrease CNS toxicity are benzos, barbiturates, as these will increase the seizure threshold, and increased protein binding, as this will decrease the amount of circulating local anesthetic. Now, additives such as epinephrine, norepinephrine, phenylephrine, theoretically, these drugs will decrease systemic absorption. However, in rats, it's been shown that these drugs may actually decrease the seizure threshold. And there are several theories why this may occur. One may be that these drugs cause a hyperdynamic circulation, thus exposing the brain and heart to higher levels of local anesthetic. Also, these drugs may reroute blood away from the liver, thus decreasing elimination and allowing them to persist in the plasma for much longer. So the incidence of these events, seizures do occur, though not so often, 1 in 10,000 for epidurals and 7 in 10,000 for peripheral nerve blocks. In terms of death or brain damage, these mostly result from epidurals. So now for cardiotoxicity, realize that different drugs have different effects on the heart. More benign drugs like lidocaine, you might see hypotension, bradycardia, hypoxia, as compared to some of the more cardiotoxic drugs. These are bupivacaine, the S enantiomer levobupivacaine, and ropivacaine. These cause pretty intense hemodynamic instability due to ventricular dysrhythmias, and some of these may be somewhat resistant to resuscitation. So these more cardiotoxic drugs, a lot of it has to do with stereochemistry. So levobupivacaine and ropivacaine are pure S enantiomers. They're a lot less toxic than bupivacaine, which bupivacaine is actually a racemic mixture of R and S enantiomers and is the most cardiotoxic of the bunch. So in terms of how these drugs cause cardiac toxicity, they can act in the central nervous system at the level of the medulla to actually cause hypotension. In terms of the peripheral nervous system, there are autonomic effects which block the sympathetic. Remember, these are some of the first things to be blocked by local anesthetics. Vasomotor functions can be blocked, causing vasodilation, so pretty much the effects at the peripheral nervous system lead to hypotension. Now at the level of the heart, local anesthetics block sodium channels. And one thing to keep in mind, bupivacaine, the most cardiotoxic, actually binds to the sodium channels more strongly. And in addition, these drugs affect the utilization of calcium by the heart. They block the release of calcium and reduce mitochondrial activity. So toxicity at the nerves, there's a theoretical risk to spinal cord and nerve roots, and at the peripheral nervous system, low risk of injury, um, especially for the clinical concentrations of drugs used. Rare incidents of radiculopathy and paraplegia. The more interesting toxicity is transient neurological symptoms, otherwise known as TNS. This is a phenomenon really described in the early 1990s, and it's probably due to the increasing amount of ambulatory surgery. With these new ambulatory surgeries, they were using lidocaine spinal anesthesia, as this drug allows for quick onset and it comes off quickly, allowing for same-day discharge. Um, so what this really is, this TNS describes pain in the lower extremities, usually the gluteal area, radiating downward. It can range from light all the way to severe. It usually begins a few hours and up to 24 hours after the spinal anesthesia, and it typically resolves in 2 days to a week, typically closer to 2 days. Risk factors are lidocaine anesthesia, like I said, with the increase in ambulatory surgery. Also, ambulatory anesthesia is a risk factor, as is the lithotomy position. So there's really no treatment for the neurological symptoms. However, you can treat the myofascial strain just with NSAIDs or trigger point injections. So the best way to treat systemic toxicity is with prevention. Really, whenever you're giving a peripheral nerve block or epidural spinal, you need to aspirate. Make sure you're not in a vein. One way to help tell if you're in a vein or not is with a test dose. Epinephrine, 10 to 15 mics per ml. If you're in a vein and if you give that epi IV, you should see an increase in heart rate by 10 or an increase in your systolic blood pressure by 15. However, keep in mind that there may be false negatives. If you have a patient who is beta blocked or who has already has general neuraxial anesthesia, or a patient who's in active labor, or sometimes just elderly patients, these patients will not respond to your epi test dose. Also, it's important to keep in mind that you have patients on monitors. Should there be hemodynamic collapse, you want to make sure you couch it early. Pre-treatment with benzos can help raise the threshold for a seizure. And ultrasound theoretically would help decrease systemic toxicity, as you can better see where you are injecting the nerve. However, there are no real good trials to show that this is superior to nerve stimulation in terms of reducing toxicity. Also, another thing I forgot to mention with test doses, you can use fentanyl, 100 mics. If you have a patient who's in labor and you don't want to use epinephrine, you can use 100 mics of fentanyl, and you should see sedation if you are intravenous. So now imagine you do have a patient who is showing signs of toxicity. The first thing you want to do is stop. Don't give any more local anesthetic. Next, ABCs, make sure patient's intact. If the patient starts seizing, some of the drugs you can go to are midazolam, thiopental, propofol. However, keep in mind that your go-to drug is going to be a benzo. Thiopental and propofol, although good for seizures, also have vasodilatory properties. And if you have a patient who's hemodynamically unstable, last thing you want to do is vasodilate. Now, say you give your benzo, patient's still seizing, still has pretty significant fasciculations. A good drug to give would be succinylcholine. Succinylcholine will not prevent seizure activity in the brain, but it can paralyze the patient and help reduce any muscular injury or acidosis that may result from the seizure. So now for hemodynamic collapse, you want to use typical ACLS protocols, but you need to make a few adjustments. So first of all, for cardiac arrest, you typically give epinephrine a milligram, but in this case, you need to recognize that epinephrine actually has some arrhythmogenic properties, and it's better to give smaller doses of epinephrine. Typically, you want to give boluses ranging from 10 to 100 micrograms. Also, for arrhythmias, amiodarone is going to be your go-to drug. Please do not use lidocaine, procainamide, local anesthetics to treat local anesthetic toxicity. Calcium channel blockers you want to avoid. Remember, local anesthetics inhibit calcium utilization in the heart, and if you have an overdose of local anesthetic, the last thing you want to do is exacerbate it by throwing calcium channels blockers on board. Latest trend is lipid emulsion therapy. I'll talk about this in the next slide, something you want to consider. And if you have a patient who is not responding to ACLS, not responding to lipid emulsion, the next step is cardiopulmonary bypass. So IV lipid is the latest for treatment of systemic toxicity. There have been case reports of IV lipid treating hemodynamic collapse unresponsive to ACLS. Intralipid 20% was used. Consider that propofol is only 1% and is not sufficient, so you cannot use propofol to treat local anesthetic toxicity as you would intralipid. ASRA recommends various dosing or a dosing protocol for intralipid. However, there's really no RCTs out there to prove that this is the best way to give it, but this is the latest recommendation as of 2010. That's it for this presentation. Thank you for watching.